And hello and welcome to Forum 360. I'm your host, Bill Stephen Souse, and we have a program where our topic is a global outlook, and we bring it down to Northeast Ohio to a local view. Today we're talking about the pandemic, the COVID-19, and we have a specialist with us. He is a medical doctor, Dr. Rajiv Sahni. And it is good to have you, Dr. Rajiv Sahni, with us today on Forum 360. Thank you for being here.
Thanks for having me.
One thing we wanted to talk about is the history, basically, of your getting involved in this specialty of this type of disease problem. So a little bit about your background and how you picked this specialty as a part of your medical career.
Sure. I did my medical school back in India at a prestigious medical school called Maulana Azad Medical College in New Delhi. And then I came to the United States for my residency and fellowship training, which I did at St. Vincent Charity, and then I did my fellowship at the Cleveland Clinic. When I was doing my residency, infectious disease was not initially on my radar. But some of my mentors were really instrumental in lighting that fire of curiosity in my heart about this specialty. A couple of things that are really cool about infectious disease is that you are dealing with other living forces, other living organisms. And like in the Jurassic Park movie, it says life finds a way.
Right.
So when you try to eliminate life, it finds a way and fights back. And that's what you're really engaged in, this specialty of infectious disease, where you're saving the good bacteria and other flora in the body, and at the same time, you're trying to eliminate harmful bacteria and organisms that are trying to damage or take life. So that balance was really intriguing to me. And so the other thing, obviously, was that you deal with all the specialties, all the including primary care, surgical specialties, and all organ systems in infectious disease. So that really kind of made me go deep into this specialty and go through the fellowship.
Thank you, Dr. Sahni. And in 2020, from China, it eventually the COVID-19, the SARS virus, eventually arrived in Northeast Ohio. How did you and the various practitioners that you worked with in your specialty come to see the problem that you had to deal with? What are some of the key issues during 2020 when the virus came to the United States and to Northeast Ohio?
Right, that was definitely an interesting time. Sometimes I reminisce about it, and those were hard times for everybody. But fortunately, United States had a little bit of a warning as Italy faced the pandemic first, and as it moved across the globe, like pandemics usually do. So we kind of got the lay of the land of what we need to anticipate, but when it hit in New York, it was still hard.
Right.
And many of my colleagues who I discussed this with at that time, they preempted us as well that this is not to be taken lightly. When it hits hard, and the resources are going to be stretched. So in Northeast Ohio here, we again had a little bit of a heads up from our Eastern Seaboard colleagues that this is coming our way. And so we kind of accumulated resources. We started planning for bed management. We started planning for isolation procedures, stockpiling personal protective equipment, and all of that. But when it got here, it was not enough. All the heads up and our resources was still not enough, because when it got here in full swing, we were still seeing our emergency departments stretched to the limits. We were seeing patients out in the hallways on stretchers. We were seeing cohorting people in rooms that were meant to be for private patients. We were seeing shortages of personal protective equipment. At Western Reserve Hospital, we had to make hard choices about reusing some of the N95 masks
Mm,
that we had because there weren't enough to go around for
right.
single use. And our healthcare workers were brave. They bravely embraced this. They sacrificed a lot, including their own personal protection at times, having to reuse equipment and masks. Did their best to clean and wipe down equipment and before reuse to protect our patients. Sometimes I call it the Super Bowl of medical practitioners, of healthcare workers, and I think we came through. A lot of people made a lot of sacrifice, be it in time, be it in resources or effort. But it was a tough time. Definitely don't want to live through that again. But I think we did okay.
I think you're right, Dr. Sahni, because at Western Reserve Hospital, where you practice, in Cuyahoga Falls, and there also their health center in Hudson. Western Reserve Hospital did a lot of proactive measures, as you said, and the mask. I remember when we were all wearing the surgical masks, like you said, because some of the better masks were depleted because of the constant use. But because the SARS virus, the COVID-19 virus, transmitted through the air, correct? So this was a logical measure to take. What were some of the other ways that people were getting this disease in COVID, different from, let's say, the influenza generic?
Right. So it was interesting because as the virus was spreading, there wasn't enough information of
Mm,
how it was spreading, and it was spreading so quickly that our peer-reviewed articles were not available to us. We did not have research that was vetted and peer-reviewed and published
mm,
properly to take a look at and say, okay, this is what the consensus is among the medical facilities and specialities and experts. So we were getting reports of trials that couldn't be very well designed.
mhm,
So the results had to be taken with a grain of salt. We also had information coming out of China, out of Italy, out of all of these places that had already suffered the pandemic in great extremes, that there was not enough time for them to be peer reviewed for quality checks and all of that. So the research was coming out, and we were just trying to kind of piece this puzzle together as to what is really going on so that we can effectively prevent transmission. So, besides the airborne transmission, closed droplet
mm,
transmission was another way that we thought the COVID virus spread, and
mhm,
it did. And in fact, initially, the droplet was deemed to be the most common way of transmission, but then airborne transmission was shown to be a very efficient way of transmitting this virus
mm.
as well. Contact and fomite transmission, which means that things that one patient had handled and were handled by other people. There was another way to transmit this virus. So there were multiple kind of ways that we had to approach prevention of transmissibility.
Now, you mentioned Jurassic Park, and you mentioned how things start to grow, and how did the various strains and that come in? Did you see where, well, we solved this one, but another strain or another variant is coming in? How did you change? You were talking earlier off the air about the injections, what you would have to make sure that people had their shots, their boosters. Tell us a little bit about that way the COVID had to be dealt with
Sure. Yeah.
proactively.
Yeah, I think uh, there's a silver lining to every cloud, right? So there's obviously a lot of grief and a lot of tragedy associated with COVID, but at the same time there are some victories.
Hmm.
I think the biggest achievement is the mRNA vaccine.
The
Um,
vaccine, right?
yeah, the speed at which it could be developed and tested, and this is an entirely novel way of developing vaccines. This has never been done before. It's just a testament to human endeavor and and enterprise. So I think that is a silver lining that came out of this. The mRNA vaccines could be made very, very quickly, and they could be produced, they could be mass produced to provide to the general population very, very quickly. And they were reasonably effective. So that's the silver lining that I think we need to take away from it. That was one. And now, like you described, though, the variance is part of the evolution of a viral illness or any disease per
Right,
se, but especially for the viruses.
right.
Um, as the disease spread and was passaging through patients, through humans, the virus was mutating and new strains were forming. And we needed to kind of be very nimble and pivot
Hmm.
accordingly. And the mRNA vaccines really helped us do that because of how these vaccines were manufactured. It was easier for us to switch the mRNA segments that the vaccines were based off of to deal with the different strains that were coming up. And so the biggest change was the Omicron virus. When the Omicron strain arose, it led to another peak,
Right,
um, pretty severe peak because the immunity that the patients and the general population had gained from prior strains was not working anymore.
right.
The virus was different enough that it could pass through, it could hide itself from the immune mechanisms that had been developed. And so,
So the Greek alphabet, the various strains were given a name or a Greek alphabet to designate them. So Omicron came a while after the initial strains.
right, and
And
that was very infectious and still maintained its virulence to a degree. And we can talk more about the evolution of the virus and how sometimes transmissibility means a little bit of sacrifice on the virus's virulence or the ability to cause severe disease.
our program is Forum 360. Our topic is COVID-19 and the pandemic and how it affected us here in Northeast Ohio. Today we have an expert, a specialist in infectious disease, Dr. Rajiv Sahni, with us on Forum 360. He also practices at the Western Reserve Hospital and both in Cuyahoga Falls, and then the primary care physicians are some in Hudson. And so Western Reserve Hospital had to deal with this very impressive, as Dr. Sahni just talked about, different type of virus. We've always had the flu shots. We were familiar with vaccination for flu. But doctor, what were some of the symptoms that you saw in this Northeast Ohio area, the symptoms that were typical as soon as you started finding the variants and the strains coming? What typically hit the people here, Dr. Sahni?
Right. So I think the symptoms were pretty non-specific and related to a respiratory disease. So
Respiratory? Okay.
Mhm. So the symptoms would range from anywhere from a little bit of a sniffles to scratchy throat to severe respiratory distress syndromes with patients needing to be on very high flow oxygen, even the ventilators, and yet having a tough time breathing even on those very advanced life support devices.
Wow.
But most commonly, the patients would have a runny nose, scratchy throat, fever, cough, chest pain, shortness of breath. Those were the most common symptoms,
And
but they would.
the body aches and that type of where you could feel your body, different high temperatures and chills and those type of things, right?
Right, right. And extreme weakness associated with all of that.
Wow.
Just malaise and weakness and just muscle aches and pains. You just feel like my patients would describe that they'd been hit by a bus.
Wow. Now, did you, when you said we know some of the patients had their vaccines or had their boosters at their various pharmacies or at their doctor's office at the hospitals. What about the people that did not get that prevention through the vaccine, did not take that, that element a part of their dealing with their disease? How did
Right.
that occur?
Yeah, unfortunately, there were a lot of misinformation associated with the vaccines, and so that led to a lot of patients opting out of the the vaccinations that were available and did not take it. Um, and unfortunately, those patients were asymmetrically more likely, had a much higher probability of having severe disease, getting disease in the first place, and also severe disease. They were hospitalized more often than the part of the population that was effectively vaccinated. And they were more likely to end up on the ventilator or a breathing machine or very high flow oxygen. They
Now,
also
yes.
shed the virus for a longer period of time.
Were you getting calls from primary care physicians, doctor, saying, when should we send them to your care, for your care and your colleagues in your specialty, in infectious disease specialty? Was there a point where you saw that the primary care physicians were saying, we really can't have many of these people come to the office because then more people would be infected? So that isolation, staying at home, not working, how did that affect your practice? Did you, hearing from the primary care doctors?
So at Western Reserve, we were very proactive as far as the dissemination of information was happening. We were collecting data that was available to us from various sources. We were analyzing it very critically, and in fact, we had regular meetings in the mornings where the primary care physician, the internal medicine doctors in the hospital, and the critical care medicine doctors were part of kind of a meeting group with myself and all the residents and the resident doctors, the student doctors in the hospitals, that we were analyzing at least 2 to 3 points of data, 2 to 3 academic articles that were coming out, analyzing them, trying to figure out how we would implement it in our practice, what part needs to go to the outpatient doctors, what information needs to go to the inpatient doctors to make sure we are treating our patients with the most up-to-date knowledge and modalities that were available. So we were doing the right thing for our patients.
Taking it one step at a time, using the information you were getting from not only the CDC, the Center for Disease Control, but here in Ohio, obviously sharing with other hospitals and regional hospitals and seeing the differences. That's an interesting point that you had to go step by step. But the admission into the hospital, doctor, what were some of the typical reasons to do the admissions as opposed to the outpatient?
Right. I think we relied a lot on the oxygen concentration that the patient was able to maintain in their blood, which is called oxygen saturation in the blood.
Okay.
As studies had shown us that if the patient's oxygen saturation was dropping to at or below 94%, they were at a high risk of developing severe disease and needed inpatient treatment with IV antivirals, possibly steroids, and other modalities of therapy. So we had it, once we had set that benchmark, then we disseminated that information to our emergency room as well as primary care doctors to educate the patients, first of all, from the offices to monitor their oxygen saturations. And if they were dropping, to come to the emergency room and then subsequently monitor again, check again, and then be admitted if they needed to be.
What about the population that you dealt with? Where did you see and I think even in the medical journals, they talk about the older patients, elderly, who were at the most severe risk that you noticed?
Right. I think just like the influenza virus, we saw that if the patients were generally healthy, did not have lung disease or other medical problems, they did reasonably well and could stay at home for the most part. But the people that we flagged out were patients who are greater than 65 years of age. With Omicron, that was decreased to 60 years of age because
Mm,
it was just a more virulent strain of the virus. Uh, Patients who had lung disease or other chronic diseases like kidney disease,
mhm.
asthma, any patients who did not have a functioning or had a compromised immune system, such as transplant patients, patients who are on medications that would
Right.
suppress their immune system, would be more likely to develop a severe form of infection.
And as you said earlier at the beginning of the broadcast, the program, you did talk about uh, New York City, where there was a large influx of the COVID-19. And you can say, basically saying that we didn't have the severity that the large cities such as New York and maybe some of the other larger cities, because our area was, as you said, a little bit less severe.
Yeah, I think it's a function of population. So the transmissibility
Hmm.
is really dependent on how many people are huddled together in a closed space or at close quarters.
Okay.
And I think in Northeast Ohio, we were blessed a little bit, if you can say that
Hmm.
the population centers are not as concentrated as, let's say, the city of Manhattan or the boroughs over
Boroughs
there.
of New York City are very,
Mhm.
yeah, very intensely populated.
Right. So that turned out to be a blessing for us. However, when the disease struck, I think the severity was no less than in someone who would have had COVID-19 in one of the bigger cities or more populated centers. So the virus does not discriminate between cities. It's just that the transmissibility is lower if we can maintain social distancing, which is rather difficult in a very highly populated city or a big city center.
Dr. Sani, what about this? They call it long COVID, where pulmonary problems stay with the patient longer than the initial problems that they had, the initial symptoms. The lungs seem to keep going with the problem.
Right.
What's your understanding of the long COVID concept there?
Yes. So long COVID happens in between 20 to 35% of patients who get COVID-19.
Hmm.
Um, it's a more protracted course of disease where even after recovery from the initial compromise, from the initial illness, the patient will have prolonged symptom that may be in the form of more chronic shortness of breath, chest pains, weakness, and just general irritability of the lungs. It can also cause problems with the COVID fog, which is how it affects the brain, where the
Mm,
patient may feel like they're not really all the way alert. It can cause issues with the cardiovascular system.
okay.
Um, most experts believe that this is because of the kind of the hypercoagulable state that COVID leaves the body in, where it leaves like a an inflamed kind of environment in the body.
Hmm. Hmm.
So the body does react to even simple problems with like with an extra kind of a very potent response. So that can happen. Now, our knowledge of long COVID is still nowhere close to complete, and a lot of research is going in this area. But yeah, that's really part of the main body of the disease that we may be dealing with for a long time.
Do we expect this resurgence? Recently, there have been more COVID patients coming back. Um, do we expect that things will eventually reduce? Do you foresee maybe it's as the original Spanish flu in the 1918 World War I era, it eventually receded. Do you hope and think that it will eventually recede to the point where we won't see it for a while? Hopefully.
Yeah, so I think that is true because we're already seeing that.
Hmm.
The CDC has provided us with data in the form of some schematics which show that the peaks of COVID-19, the peaks right now are going down slowly. So they're not nearly as high as the peak in 2020 or 2021. The last peak in this past summer, in this past winter, and it was also much higher than what we anticipate during this time. Now, it is the nature of the virus, though, to cause these peaks and valleys in
Okay.
in just its prevalence as time goes. At this point in time, COVID-19 is going to become what is an endemic disease if it hasn't already, which means that we live with it, just like we live with the influenza.
Very good.
The virus has some particular characteristics, though, that are different from the flu or the RSV virus in the sense that it does circulate all year round.
Well, I
And
want
there,
to thank you for bringing that, the final summary, so that we do see there's some hope. We're at the end of our program, but we were fortunate to have Dr. Rajiv Sahni with us. He is at Western Reserve Hospital, and he is an infectious disease expert. Dr. Sahni, thank you for sharing how COVID-19 is happening here in the Northeast Ohio area. Thank you.
Forum 360 is brought to you by John S. and James L. Knight Foundation, the Akron Community Foundation, Hudson Community Television, the Rubber City Radio Group, Shaw Jewish Community Center of Akron, Blue Green, Electric Impulse Communications, and Forum 360 supporters.